cast in a slight plantar flex position. And when he gets a cast in 10 or 15 degrees of plantar flexion, then it's really difficult for him to come back over 0 degrees. If you fix it with 4 or 5 degrees of dorsal extension, yeah, then it's much easier for him to get the dorsal extension. And the other side is back to sports. That's difficult. It's because it depends on the sports, but that's not the target. For me, the target is to hold ankle joint and subtalar joint. And if you have an post-operative an arthrosis of the subtalar joint and a good working ankle joint, you can make a subtalar fusion and the patient will be happy. The worst thing is really the tibio-talar calcanea fusion for a young patient, because with this, my experience, they don't become happy.
Thank you. So if you don't have questions, we can go to the next presentation. I have a very big pleasure to present Professor Hans Wipp. Dear colleagues, the most of the papers, the most of scores and classification in the foot surgery come from Professor Zwipp. So, dear Hans, please present your presentation, intraarticular fractures of the calcaneus plate or nail. Thank you very much for coming.
Yeah, so Florian, thank you very much for this kind introduction and inviting me here. So I'm the first time and I want to deal with you, dear colleagues, my experience of 36 years in treating calcaneal fractures. And where is the pointer? You took it? So if you have a calcaneal fracture, it's like a broken house. And we have 3 main facets we should reconstruct. And the question is, do we use a plate or do we use a nail? And so I want to report about this. We had a complete change of the paradigm in treating calcaneal fractures in the 1980s, when we had the information by the upcoming computer tomography, because before we did not understand the pathology of these fractures. And so there was a very important paper in clinical orthopedics in 1983 by Bordeaux, and he reported that he had good experience by using a medial approach according to McReynolds, and he just is able to rebuild the medial wall and to reduce the posterior facet by this approach from medial side. So we thought this is a good idea, and we started in 1983 with this, but we saw that it is not so easy to reduce the posterior facet, and so we started with a medial approach, but for the posterior facet, we switched to an additionally lateral approach according to Palmer, which is now a little bit shorter as a sinus tarsi approach. And with this approach on the lateral side, you can reconstruct the posterior facet. So we had a bilateral approach with a little H plate with some screws, and this worked quite nicely. And with the CT, we made a study, and we could see that in most cases, we have 4 to 5 fragments, which is the sustentacular fragment, the tuberosity fragment, the anterior facet fragment, and the posterior facet fragment, and the anterior process fragment. So we came up with this X-fragment Y-joint classification in 1988. And Roy Sanders, he made his own classification with ABC and 1 to 4, and this is now the most often used classification internationally. And later, with the AO foot and ankle expert group, we saw that we have also to take in consideration not only the extra-articular fractures in 5%, but mainly we have the intra-articular ones, but you have also the so-called C fractures, which is a fracture dislocation. And you can see that more than 50% of the posterior facet is now out of the confines, and this we call a fracture dislocation. So if you look how the development was to approach these fractures, we took over the Seattle approach, and Stephen Benirschke from Seattle said to me, for which fracture is this approach not suitable? So in Hanover, at this time, we changed and we started with the extended lateral approach, which is oriented here, just below the fibula and behind close to the Achilles tendon. So the standards of the operative management for the extended lateral approach is that the patient is in 90% in a lateral position. We use the extended lateral approach. We use intraop X-ray or fluoroscopy in 4 planes. And what we like to do is to use intraoperatively open arthroscopy to control if our posterior facet is really reduced anatomically. This is very important. And we just use a tourniquet for the joint approach for 45 minutes. So this is the exposure, and we like to use 3 to 4 K-wires, which are here in the talus, and one is in the cuboid, just to have an exposure, and then we have time to reconstruct the whole intra-articular situation. And what we have learned mainly for reduction is, if you have such a tilted sustentacular fragment, you have to correct this at the very first step. That means that you have to put in a K-wire from plantar side and keep the reduced sustentacular fragment to the talus. And then you can reduce your intermediate fragment here, and you go out with your K-wire medially, and then you come back when you have reduced the main posterior facet fragment here, and you go back with your K-wires and then change it for screws. And this you can see here. If you don't do this at the very beginning, there's no solution, and there will be an incongruent subtalar joint left. So how is the history of calcaneal plate fixation? In the 80s, we had only this triple or single H plates. We had to combine those, and in very complex situations, we used additionally a medial approach for the broken sustentaculum with a medial facet, which is also important to repair. So in these days, in the 90s, we still had to deal with these triple H plates just for refixation, and it took a while before we had the first anatomic plate for the calcaneal fractures, which is the AO or the Sanders plate. It was introduced by Roy Sanders, and we have learned if we use in these complex fractures this anatomic plate, which is a non-locking plate, we have to use in minimum 5 to 6 screws, and they have to run into the sustentaculum from here. They are close to the calcaneocuboidal joint and far dorsally, because there is a better grip of the bone. This is very important if you use a non-locking plate. And if you have such a non-locking plate, these 2 screws have to run in the sustentaculum, because in this position, everything becomes stable and you have enough buttressing by your plate. So what have we learned as well in the years? We have seen that using an open arthroscopy, we have to look if everything is anatomic. And we made a brief study and could show that in 22% we had to recorrect intraoperatively the posterior facet because it was not anatomic. So arthroscopy is more helpful than intraoperative X-ray or 3-dimensional reconstruction by X-ray. So in acute compartment syndrome, we have learned that we have to measure, and when we measure the pressure of the soft tissues, and it is more than 25%, we will speak about a compartment syndrome in addition to the calcaneal fracture. And in those cases, we started to make, in the 1980s, we made a dorsomedian incision here. We used an external fixator. Then after a couple of days, we could close the skin again and do our open reduction and internal fixation. And this was the very first case in 1992. A young lady, a nurse, who came with this fractured calcaneus, and she had a very acute compartment syndrome, and the mercury was 62 millimeters. It was extremely with blistering coming up, and in this case we decided, and this was the first, and we went on in this way, just open it immediately, take out all the hematoma, and then everything, the soft tissues are released, and fix it with a plate. So everything is done in one step. And we went on with this because we had very good experience. And you can see in this young nurse, after 20 years, the joint is still absolutely intact, no arthritis, and a very good function of the ankle joint and the subtalar joint as well, after 20 years. So in polytrauma patients, you have not the time to do everything. So you have just to do a dorsomedian release, as I showed you, and we would combine this with a medial external fixator because you bring down your tuberosity fragment so the skin cannot shrink, and then therefore you have time to do open reduction, for example, 3 weeks later. This is possible. But if you would not use a medial external fixator, the skin would shrink and you would have problems with skin necrosis. So the history of calcaneal plate fixation is that in the year 2000 we did our first anatomic interlocking plate fixation, like in this case, a severe intra-articular fracture of the posterior facet, intra-articular fracture of the calcaneocubital joint, and so we used this interlocking plate here, and you can see that you can do an anatomic reconstruction of the posterior facet, and you have a stable fixation in this multifragmentary situation of a calcaneal fracture. What have we learned as well related to soft tissue trauma? So this was a young boy who fell from the 5th floor. It was not quite clear if it was a suicide or not. So he had a lot of fractures, and it was life-threatening. So the pediatric surgeons were taking care of him, and he came to our unit after 18 days, and you can see the severe skin and soft tissue necrosis here. So we decided in this situation to make a complete nephrectomy of all the dead soft tissues, covered it here with artificial skin, and then next day the plastic surgeon did a free flap on the medial side here. We reconstructed the calcaneus, and everything healed quite nicely. So you have to take care of the soft tissues, otherwise you will have catastrophes like in those cases. If you compare related to complications, so in overall, our complication rate is not so high if you have closed fractures. But if you have open fractures, the complication rate is 7 times higher. And this is related to wound edge necrosis up to bone infection, 17% in open fractures. So we have learned by this experience that if we have a 2nd or 3rd degree open fracture, we have to use an early free flap coverage. Do a radical nephrectomy, like in this case. This is just on day 1. And then within the first 5 days, you should do a free flap coverage with a plastic surgeon. Otherwise, you have a high risk for bone infection. And so if you do a free flap, it heals without any infection. So what have we learned also in these years? I told you that we have about 5% of fracture dislocations, and they are very often overlooked, like in this elderly lady who fell from a tree, and you see that the whole posterior facet is out of the joint, and so in this case, when it's inveterated, it's very difficult to reconstruct anatomically. But it was seen initially, but she was treated for a distortion. So keep in mind that these fracture dislocations are very easily overlooked, and they are very unstable, and so you have to take care for these very precisely. Like in this young man who had a fracture dislocation, you see how from below the calcaneus came up and destroyed the lateral malleolus as well. So we have a two-joint problem. It's a C2 fracture because two joints are involved. And in these cases, we have to use a bilateral approach. This is a special approach for the fracture dislocations. And in addition with the medial approach. And you see here from the lateral side how the posterior facet is destructed. This is a comminuted lateral malleolus fracture. And so step by step you can reconstruct also the lateral malleolus. And on the medial side we have just a two-plate, only this little two-hole plate on the medial side, just to keep the wall in a correct position. And this is for the anterior part to reconstruct the anterior process. You can do an anatomic reconstruction in these severe fractures, like in this case, this is after 15 months with not any subtalar arthritis. So how is the post-operative care? Elevation of the foot, range of motion. We like to start with a passive motion machine here, and with active exercise, just writing a circle with the big toe. This helps you to regain movement in the subtalar joint, which is very important. And if you have a fracture of both sides, we have special boots which take the weight bearing for with the tibial head, and you have to do full weight bearing. You can do full weight bearing depending on the kind of fracture after 7 to 12 weeks. Hard work and sports after 4 to 6 months. And if we do hardware removal after 1 year, we like to combine this with arthroscopy to mobilize the subtalar joint and make it more mobile. This is a very important point. Contradicting goals in calcaneus surgery. From literature, we know that there have been some reports with infection rates up to 25%, wound edge necrosis up to 27%, and therefore we started at the 1990s how we could go other ways to do it, minimize the surgical approach. And from biomechanical study, on the other hand, we know that we have to have a very precise subtalar joint. If you have a little step, the load distribution is very different and leads to post-traumatic arthritis. So we were thinking about how can we combine minimal invasive procedures with stable fixation. So we decided in 1995 to start in some fractures with closed reduction, with a shank screw here, with an arthroscope from posterolaterally, and by percutaneous using a pestle to lift up the posterior facet, but controlling the reduction by arthroscopy. And we have done this by open arthroscopy, but you can do this also closed by an anterolateral or posterolateral approach with arthroscopy, just to control if everything is reduced precisely. So like in this case, this is at the beginning, and then after reduction, it is anatomic, and you can fix it if you have a good bone stock only with screws brought in percutaneously. So we saw this in a small study that this works quite nicely, like in this elderly lady of 76 years. So this is by arthroscopy, the step up here. This is the interosseous ligament. And now, after reduction by percutaneous pushing up the posterior facet using a shank screw, you can make this anatomic and fix then the fracture with screws. Here we use 6.5 screws, hole threaded to keep everything in position, and this makes sense to do it. So in this small study, we could figure out when we do open approach or percutaneous approach, more or less all is the same outcome. But the only statistical significant difference was the motion of the hind foot. And you can see when we go close, we have only 10% who have a significant stiffness of the hind foot. But if you use a plate and open approach, it's 28%. So it's almost 3 times higher. And so therefore, we came to the idea to use a minimal invasive procedure and combine it with a stable internal fixation. And this is only possible with an interlocking nail because you have screws which run into the sustentaculum through the nail. And with this, we have a very high amount of stability. So for example, we started with this case. It's a B2 fracture, broken posterior facet, broken anterior facet, and calcaneal facet. So with a small incision here of about 2 to 3 centimeters, we can control the posterior facet, and we use a nail which is inserted just below the Achilles tendon, and it runs here in the middle, close to the calcaneocubital joint. And so with these 3 arms, we can guide first the K-wires and then the drilling and the screw insertion. And we have only tiny incisions. So with the sustentacular arm here, we start at the very beginning when the nail is inserted, guided by a wire. Then we first go with a K-wire, and we want to know if this K-wire is running into the sustentacular fragment, which is very important. And then we control this with an axial view intraoperatively. And when we see that this K-wire is right in the position of the sustentaculum, then we will take the second K-wire in the sustentaculum. And if the second is also in the sustentaculum, then we can change the first K-wire with a screw. And then more or less everything is done. This is a very important step for C-nailing of these intra-articular calcaneal fractures. This is the postoperative control. This is a CT scan after the operation. And this is our first report we gave in 2016 in the Journal of Orthopedic Trauma. These have been the first 106 cases we did only with C-nailing. You can see that the RFA score was going up to 92%. The Böhler's angle changed from 7.3 degree to postoperatively 31 degree. The posterior facet was preoperatively about 5 millimeters dislocated, and postoperatively more or less 0.7. Complication, and this is very important, if you look to the plate fixation, the wound edge necrosis was very low with 1.9%, and the deep infection was less than 1%. This is my main message to you, that with this calcaneal fracture fixation with a C-nail, and we made a cadaver study as well, we have a very high stability using the C-nail, which is much more stable than an interlocking plate, and the French calca nail, which is also not so stable like the C-nail we use. And this was a statistical significant improvement by the C-nail, making it stable. And if you compare, if you look into literature, if you compare plate fixation and extended lateral approach, so we have a better biomechanical situation in the cadaver study we made. Hematoma, if you use a plate, is up to 6%, and here for the C nail, it's only 1.9%. So related to wound edge necrosis, it has come down to 1.9%, and infected hematoma has come down up to 0.5% in our study. Deep infection, only 0.9%. And what is also important, that we don't see any damage to the sural nerve if we use the sinus tarsi approach and the C nailing. So the ROFAS is comparable. With a plate, we have a long-term result. With the C nail, we don't have. But meanwhile, we use the C nail for 8 years. And Mr. Pompach, my co-author, who is from Czech, he will present this paper now next days in Berlin at our annual meeting. And so he has done 265 cases. Most of them were closed fractures. 2.3% were open fractures, which are the dangerous ones. We have heavy smokers of 45% in this Czech population, and diabetic patients in 7.5%. And the results, Böhler's angle is improved up to 32 degrees. Posterior facet is improved from 5.6 to 0.7 millimeter. The ROFAS is 90.5. Wound edge necrosis, very low, 1.1. Infection, superficial and deep, 0.8%. And no sural nerve damage, which is very important. So in summary, I can say that ORIF of calcaneal fractures started in the 1980s due to CT analysis. Extended lateral approach became the standard one. Anatomic locking plates are preferred in comminuted fractures. Close reduction internal fixation only with screws is critical in osteoporotic and comminuted fractures. If you have a good bone stock, it works perfectly as well. The C nail works also in osteoporotic and comminuted fractures, which is very important. And the sinus tarsi approach and the C nail is a minimum invasive procedure with very less complication rate of hematoma, wound edge necrosis, infection, and no sural nerve damage. So I thank you very much for your attention.
Hans, we thank you very, very much for very useful, didactically and perfect presentation. Please, for comments or questions. Dr. Osman Jouri, please.
Yeah. Professor, thank you very much for your nice presentation. My question is about the C nail, because we are not experienced, we have not this kind of nails here. My question is, how you use it in the open fractures of calcaneus? Do you use, first of all, the external fixator or going straight to the C nail?
Yes. So Mr. Pompach, my co-author, he decided for himself to do all fractures which are coming into his hospital, to do it with a C nail. And so, as I showed you in the forelast slide, we had some percent of open fractures, and we recommend to do this also immediately with debridement, with internal fixation with a C nail, as I showed you, and coverage it with some artificial skin. If it's more than 2 degrees, we recommend to do a free flap to prevent infection. But Mr. Pompach, in his cases, he did not need any sural flap or some microvascular flap. He did all his open fractures just with temporary fixation, with sucking, and then doing a skin graft.
Hans, extended to the open fracture, when is the best time to do surgery in the calcaneus fracture?
In open fractures?
No, except at the open. No.
In close fractures? Yeah, so when you use a plate, the standard extended lateral approach and plate fixation, in most cases we operate it after 8 to 10 days. But if you use the C-nail, the earlier you do it, the easier it is. This we also have seen when we did closed reduction and screw fixation. And the same is for the C-nail. The earlier you do it, the easier it is.
Thank you. Question, comments? Microphone for Professor Mjekësisë.
Thank you very much. Very interesting topics. Are there some similarity in the using of intramedullary nail in the long bones fracture with calcaneus fracture?
Yeah, so I think the only parallel is that you have a high amount of stability by these interlocking screws. It's a different bone. We have not a bone marrow.
Yes.
But if you position the nail in the right position, it's a little bit more lateral than in the medial line. And if it's just going into the calcaneus below the Achilles tendon, and it's running in the middle height of the CC joint, this is the ideal position. And then when you go with two sustentacular screws through the nail, you have a very high amount of stability. And this is, I think, the parallel to the long bones, that if you use an interlocking nail, you have a high amount of stability.
Thank you very much.
Thank you. Hans, thank you very much for a very good presentation. Thank you. Dr. Arben Koqiqi për shkak një operacionit nuk mundet me bërë prezentimin, kështu që po shkojmë në prezentimin e ardhshëm Dr. Alexander Mugosha. Please for your presentation. Thank you. Dobrodošao. Prezentimi i Dr. Mugoshës është zhvillimi I qendrës për kirurgji kardiake në Malin e Zi.
Yes. I can take my computer.
Okay? Why you do that? Now it's okay. I will do one. Now it's okay. I'm sorry because of technical problems, of course. Dear colleagues, conference participants, Mirdita, first of all, I would like to thank Dr. Pleurat Saidi, President of the Kosovo Medical Association, and Dr. Rezar Khalili, the Vice President of Kosovo Medical Association, because they invited me to speak at the first Congress organized by the Kosovo Medical Chamber. I want to say also that they are my dear friends, and I have great respect in front of their work here. And we changed our experience for the last 2 years many times, and I wish luck to them, and of course I wish luck to all of you. Like you see, I come from Montenegro, your neighboring country, similar in size with a smaller population. I emphasize this because sometimes it is easier to organize the system and create the conditions for its functioning in small states and small societies. I'm sorry because of my English, it's not so well. Because of that, I must read what I wrote. The health system, I want to say a few sentences about health system. The health system is complex. It is in fact the most complex system in all countries, whether large or small, financially more powerful or weaker, with high or low GDP. There is no country where the health system functions without significant problems, precisely because of its extraordinary complexity. It is also thus that it is extremely difficult to isolate the health system from the general social environment in which it is located. What matters most, and what you have to explain to your politicians, is that every successful healthcare system is based on the work of medical doctors and other healthcare professionals. That the issue of healthcare is the most important national, and if you want, the most important patriotic issue, because a healthy nation is the first and basic prerequisite for state survival in general. For this reason, the issue of population healthcare must not be a political issue, that is, it must not be a political interest of any group or party. It is simply a national issue. The product of your knowledge and skills, naturally resulting from hard and responsible work, is a healthy individual and healthy nation. Such product is therefore priceless, which makes your work a noble act of patriotism that no one can despise under any circumstances. I had to say all this at the beginning because I still think that practically all that is happening in the healthcare system of a country is interconnected, and that we must not forget this. I will show you some basic data about my country, small country like yours.
only we have less number of citizens, 630,000 citizens, and we have 33 public health institutions and more than 2,300 physicians. This is clinical center of Montenegro, the building in which I work also. And this is part of intensive care unit in Department of Cardiac Surgery where I work. And today I will speak about development of the cardiac surgery in my country. We are in a similar position, and that is the reason why I'd like to share our experience with you. The cardiac surgery project in Montenegro started in the late 1990s in response to the needs of the Montenegrin citizens. Back then, we were still living in the state union, but our citizens who needed cardiac surgery treatment had to be transported to another country, which was extremely problematic for everyone. The idea of cardiac surgery had previously been offered by Montenegrin politicians who wanted to bring along some superstars and their grand promises and expensive demands. Of course, these were people from the outside who have no sensibility for the country they come to, who have no friends, neighbors, relatives in the environment they come from, people whose sole and exclusive interest is profit and personal affirmation. Of course, the idea was never put into practice for a number of reasons. First of all, I think politicians do not understand the complexity of our job. They only notice us when they or someone important to them get sick, and soon afterwards they forget others. Another much more significant reason is the fact that cardiac surgery is complex. Teamwork is essential for the success, involving a large number of well-trained physicians of different specialties and medical staff specifically trained in cardiac surgery work. Thirdly, it requires standards and strictly controlled procedures for the simple reason that it is dangerous in itself, that this type of surgery have the largest percentage of possible poor treatment outcomes or the highest potential mortality and more importantly, the largest percentage of potentially serious complications. This is one photo from our operating room. Implementation of this project started once the Montenegrin doctors became in charge of the organization and the project of creating Montenegrin cardiac surgery. The project started as an interstate cooperation between Montenegro and the Republic of Italy, more precisely the region of Abruzzo, which has a significant Albanian population. Thus, state assistance is certainly necessary, but professional issue must be left to the professionalists. The first two Montenegro general surgeons committed to cardiac surgery spent 24 months in Italy working with their Italian colleagues. 5 cardiologists received months-long education for cardiac surgery jobs. 3 anesthesiologists committed to cardiac surgery were also trained in Italy. 30 medical technicians, many of whom already have invaluable experience in patient care, were also educated in Italy. In parallel with the staff education, one part of the clinical center of Montenegro was adapted with all the necessary equipment was purchased under the supervision and instruction of Italian colleagues, of course. The whole preparation took 5 years. The first operation was performed in March 2003. For the first few years, we worked with the full support of Italian mentors in the way that they visited us in the first year. Surgeon, anesthesiologist, medical technician, and assistant anesthesiologist, medical technician working on extracorporeal blood flow, and medical technicians for instruments. We gained experience with them, and then the results were more than good. We did a small number of operations in the first few years. The number of operations in the first few years was 150 on an annual basis. When we also received a third trained cardiac surgeon and reached the number of 6 trained cardio anesthesiologists, in the 6th year of operation, we increased the number of surgeries to 400 a year. We have, at present now, the 3 of us perform between 450 and 500 open heart procedures a year, and we cover entire cardiac surgery pathology. We do not have a waiting list for cardiac surgery patients. We do not refer our patients to receive treatment outside of Montenegro. We have 3 more junior cardiac surgeons who work with us and intensively preparing for independent work. We do constant quality evaluation, short and long-term follow-up, and I can say that our results are at the European level. Achieving the same quality of healthcare and results of work in Montenegrin conditions compared to our colleagues in development Western Union countries, where our colleagues have all the necessary resources available, it is great success. We need to keep in mind that our patients usually come at later stages of the disease with much more comorbidities, and therefore the preoperative risk score of our patients are much higher than the predictable outcome of patients' treatment in Western Union countries. This makes our success even more significant, of course. Also, it is not negligible that the stress we are exposed to during work is much higher for a number of reasons. Small population, so we personally know most patients. Then we have situation in my country, spectacular lawsuits in our country against doctors, negative publicity, and the attitude of media in relation to our work, excessive political influence, poor regulation, and many other reasons. So, from the early beginning, from the first operation, we started standardizing all procedures from patient admission to hospital to discharge. It means that we insist on the concept called safe cardiac surgery. So, in order to succeed in some extremely demanding business in countries like mine and yours, in the profession we are dealing with, and in perhaps the most demanding field of medicine, in my experience, the most significant goals are good and careful preparation, good project, whose design involves only expert person. The state is only there to help, because someone said the fail to prepare is prepared to fail. Of course, good selection of personnel, standardize the procedure from the beginning, continuing medical education, and workplace responsibility. That I can say also that the key of our successful work is teamwork, development in step-by-step mode, continual medical education of staff, and standardized procedure. All this, of course, takes time, but we need to remember that people will be born here in 20, 30, 50, 100 years. Because the flow of time is constant. The flow of time is not going to stop. For this reason, pioneers in each business are also, in part, victims of that pioneering behavior. If in your country, regardless of all the challenges, you decide to sacrifice for the benefit of both present and future generations, then by definition, you are patriot. And that is nice feeling, or at least it should be for all of us medical doctors, great satisfaction. Society, on the other hand, has to recognize and reward you all, and step by step, little by little, we are back to the beginning of my presentation. Definitely, society and medicine are keeping peace. They are developing or failing at the same time. Medicine is often forced to go ahead of society because the product of our work is the most valuable category and the basis of all. It is life. So, burn it out and try to be ahead of the society in which you live and work, because your product is the most valuable, more valuable than any other social products. Preliminaires.
Alexander, thank you very much for your presentation. I wish you good work and the progress in the cardiac surgery, and I hope you come in the finish. If you need a support from orthopedic and trauma surgery, I can support you. So, if you have any question or comments from the presentation from Dr. Mugosha? Okay, no comments, no questions, then we go to the lunch. Thank you very much for this session. Thank you very much.
Sorry, because
No, it's fine.
my fault.
No, don't worry about it. It's fine. It all went very well.